Thank you for coming. I'm excited about this talk because the orthopedic exam, of course, it's one of, for obvious reasons, it's a topic that's dear to our hearts here. But it also tells me that there's a bunch of you out there that are interested in fleshing out their orthopedic exam, which I do think it's important. Even if just to get the basics that the general practitioner can and should perform some semblance of orthopedic exam when their clients and patients are showing orthopedic problems. So that said, let's just go ahead and get started. We'll kick this off. Sorry about that, you guys. I don't know how long I was muted for, but I guess maybe I didn't know how long I was muted, so let me just go ahead and repeat that. Basically, what I was saying is that I want to recognize the fact that this approach can be functional. I get it, but I know that we're all here to see if we can't flesh this out a little bit better. All the way from, like maybe your structure of the schedule that you have isn't really set up to do much in terms of time allotted for full examination and diagnostics and whatnot, and it's easier or faster or more efficient for you to just see a limping dog and refer it. I recognize that as a limitation. I also recognize as a limitation that some vet schools, I might be, as I was saying before when I was muted, as I might be dating myself and saying that I've heard through the grapevine that orthopedic rotations are optional now at a lot of vet schools for various reasons, just because they're discovering so much that the general practitioner needs to know and is responsible for, that for some vet schools, the orthopedic component of that has fallen by the wayside as an important part of just the basic general examination. So for those of you that are here to try and help flesh that type of thing out, I'm grateful, for same idea. It's like if you want to flesh out your soap notes a little bit more for the dogs that present to you limping, we're here to see if we can't flesh your physical exam notes out a little bit more than this. So for example, you could even, like I said, it doesn't need to be, in the end, it doesn't need to be extravagant. It doesn't need to be, so detail oriented specifically, but let's just the basics to know that, I'll end up using cruciate tear as a very common touchstone here, just because it probably is the most common orthopedic injury that we're going to be interacting with in terms of the general practitioner to the referral based or to the specialist referral. So, a left hind limb lameness, I guess you don't have to be exhaustive, but the basics, the most common thing would be the torn cruciate ligament. So all the usual things that go with the torn cruciate ligament, palpating for drawer, palpating for medial buttress, palpating for joint effusion, things like that, would end up getting them, in most cases, to the right spot, getting the owner to the right spot and saying, well, either we offer this surgery here, or you can go get referred, blah, blah, blah. But in terms of client experience, a more fleshed out exam notes might be the difference that it takes to send somebody to a neurologist as opposed to an orthopedist. And so mainly what we're looking to accomplish here is we're trying to accomplish the best and most efficient patient and client experience in terms of trying to get to the bottom of their pet's problems. And sometimes if there are hiccups along the road, like, they get sent to an orthopedist when they actually have a neurologic problem, there can be hangups like that. So it's recognized that this approach could work. But you need to hear it. In our experience, it probably only works a good 70% of the time. There's maybe a 70-80% of the time this will get the client in the right place. But I think we should recognize that there's probably a good 20 to 30%, which is not an insignificant percentage. 20-30% of these clients will end up in the wrong place. And then we'll end up having somebody will end up having to re-divert them to the right place, shall we say. So we're aiming for the most efficient, client and patient experience for your clients and patients. So we'll go over the fact that, at first, you're going to want to determine, from the general examination, there's a whole lot of things that you can just discover from afar. I mean, is what I'm looking at an orthopedic problem or is it a neurologic problem? First things first. I do want to start getting you guys thinking in terms of differential diagnoses, because that's an easy way to wrap your brain around how to systematically go about your orthopedic exam. Because you can, divide your orthopedic exam into regions, into joints, into bones. And then with each one of those regions or joints or bones, you have a list of the most common, orthopedic differential diagnoses. It doesn't need to be exhaustive. You don't need to find the red herring. You don't need to find the diamond. Well, the diamond in the rough is the wrong analogy, but you don't need to find like the needle in a haystack type of diagnoses or the unicorn diagnoses. But it's useful and helpful to at least have the most common things happen commonly. So it is useful to have the most common differentials in mind when you're doing your orthopedic exam. And so our job today is to try and get you into a more comfortable location with this. Again, this talk isn't going to necessarily turn you into an expert, but I do want to get you back into a place where you're more comfortable and where hopefully you found this talk helpful. Okay. Also, there's diagnostics that can be done at your clinic, and we'll go to that as well, because that could be useful in terms of getting the patient where they need to be, or getting the patient treated as efficiently as possible. So in the end, diagnostics or not diagnostics, then yeah, you do have to decide, is this a case that we can just handle here just fine, or is this a case where we need to refer? In terms of referral, I mean, a lot of this also is directing you and your clients, as I was saying. I guess I don't want to repeat it in too many ways, but like which one of these places is the right place to refer it if it's not going to be a problem that you guys can handle in your own clinics. Then where do I send it? These three in red are basically, our departments, the orthopedic surgery department. And actually, in terms of orthopedic medicine and rehabilitation, those, are mostly handled by our Sound Veterinary Rehabilitation Center. For anybody that wants to hear a little bit more about that, I do have a little bit of a blurb in the end that I could go over after this talk. That's that if you wanted to learn a little bit more about the referral process specifically internally to us, then you can feel free to stick around after the talk here. And if enough people stick around, I'll go over that in a little bit more detail. But some of these cases, their limping is neurologic. Some of these cases, they actually have multiple joints that are swollen and they're acting sick, like they have Lyme disease or they have immune-mediated polyarthritis. And some of these cases, might actually have a tumor in the bone, which, in all reality, certainly if they come to us on the orthopedic surgery side, we will be able to, move forward with those diagnostics here. But in the end, a lot of those cases, we will probably be referring them onward to somebody else. And so potentially taking away from the patient-client experience. So if anything, I could even put a bit of a plug in for a Bridge Animal Referral Center for this oncology bit here. I mean, those guys have board certified oncologists and a board certified surgeon who practices surgical oncology all under the same roof. So potentially there are some of these cases where the most efficient thing to do, if you discover an osteosarcoma, maybe they're the right practice to go to directly, or maybe we have the first opening, you know what I mean? So that might be a reasonable thought process and way to go as well. So let's get on with the orthopedic exam. First things first, I was saying, you can get a lot from just the general examination. Of course, this comes after the fact that they've scheduled their appointment. You already have a signalment in your mind. You already have a history in the appointment schedule. So you know why they're coming. You know what breed it is. You know what age it is. You know how long the thing has been going on. And then you start your distant observation. It's like some dogs, they present like this. And in your brain, you're already formulating differential diagnoses until the owner tells you that they're there for a left rear lameness. So yeah, there's a lot that you can glean just from looking at the dog, and writing those things in your notes is certainly helpful. Again, then you look at their gait. I've got some videos here coming up where we can try and help determine between neurologic versus orthopedic. But there's a lot that you can glean from this just from observing them from afar. I like to say that no veterinary talk is complete without a cute puppy video. So I don't know if you agree with me. Certainly, whatever. I have no way of telling if you agree with me. This is sort of I do miss sometimes our in-person talks that we used to give, because I could get actual feedback from the audience as to whether or not people were falling asleep. But puppy videos help people wake up. So this. Obviously, for me, I don't want to say obviously necessary for you, but this is clearly, the owner might describe this as a limp, but we see it as an ataxia. So clearly, right from the onset, regardless of what you guys are, depending on how much you guys want to do at your own clinic versus how much you want to refer, but this in general, this would probably lean a little bit in the end towards a neurologic referral as opposed to an orthopedic one. Similarly, you get a dog, an owner might describe this as a limp as well, but to you and I, this dog clearly has proprioceptive deficits in the rear. To us, this is a T3L3 problem, probably likely going down the neurologic pathway as opposed to the orthopedic pathway. Now, in terms of lameness, let's go ahead and get into that. Forelimb lameness, remember, the forelimb lameness is defined by the head bob. And a lot of owners know this inherently themselves, because they're already coming in telling you that their dog has a left forelimb lameness. But it is useful. We are the medical professionals. Remember, it's useful to try and remember how we evaluate that officially is that they're going down on the good leg, up on the bad leg. So you can see that this dog's head is dropping down on its right forelimb and it's popping up on the left forelimb. And so this dog has a left forelimb lameness. Same is true for the rear leg lameness. Clients often obviously themselves already are saying this is clearly our right rear lameness. And we don't really need a continuing education on this, but in my mind, I'm just saying like the differential diagnoses are jumping in your brain. Yes, it's the most common things that cause this. But there's two levels to that. You are listing the most common things, but you're also keeping in mind, hey, there are some weird things that can cause this too that I need to make sure that I rule out first. I can't just presume this is a cruciate until I get my hands on the dog and make sure that it's a cruciate. There are some hind limb lamenesses that clearly are not cruciates. You know what I mean? There's visual inspection will give you a list of differential diagnoses for this. You can certainly put this in the category of a sciatic deficit, but they're probably more frequently you're really going to be trying to really hone your exam on the Achilles tendon, the common calcaneal tendon, and checking that out and seeing if it's intact. So you can see a lot before you even, in a sense, this is already the orthopedic exam is started, but before you even touch the patient, then you already have some differential diagnoses in your mind. Now, I get it. I put this slide up not because I'm expecting you guys to read. This might even be small on your screen. And I'm not really expecting to read all of those words, but it's sort of, I want to pay credence and respect to the idea that thinking in terms of differential diagnoses can certainly be intimidating. Yeah, there's a lot of differential diagnoses out there, but it is useful to try and at least keep the most common things in mind. You know what I mean? And so if you can read through these do end up being the most common ones, you know. And so, but this is sort of an example of how an orthopedist thinks. You know, it's like if you see it, how this sort of this table or this table works is like, you know, we're thinking in terms of like major categories. Is it a pelvic limb? Then it's these things. Is it a forelimb? It's these things. Is it an adult dog? Is it a growing dog? Is it a young, you know, signalment, history? Is it a large to medium breed versus a toy breed or a condrodystrophoid? Because all of those would intersect with different different differential diagnoses. And these three things at the bottom of all these lists: medium to large, toy, condrodystrophoid. This is sort of a weird way, I suppose you could. I'm sure somebody smarter than me could sort of express this in a Venn diagram as well. But this is sort of an example of how we think anyway. So when you're thinking in terms of region, forelimb, hind limb, you're thinking in terms of signalment, you're thinking in terms of joint, bone, that sort of. So yeah, this is what I'm trying to say here. As far as the standing palpation versus the recumbent exam, well, basically there, you know, it's going to end up being a confluence of what the dog's most comfortable with and what you're most comfortable with, you know. So you do have to read the room as to whether some dogs are actually a lot more relaxed laying down, and they'll roll over into that sort of submissive position on their back, and that gives you the perfect angle that you can palpate for cranial jaw or patelloluxation or whatever. So you do kind of have to take your patient into consideration and try and do everything you possibly can to make the exam as stress-free as possible and as happy as possible. I try to do a lot of my exam with the dog wagging their tail in my face, you know, thinking that I'm petting them, thinking that I'm socializing with them. The more I can kind of hide my palpations into something that looks and feels to them like something social, the more I can get away with. In fact, I've gone through some of my orthopedic exams where I've started, as I'm talking to the owner, started and finished my entire exam, and the owners are confused because they hadn't even realized that I started. So anything like that can go under the radar and improve the patient experience should be. And there's not, I don't think I have any tricks specifically to tell you guys about that. It's just something that develops over time. If you find that standing a certain way for the dog, they find less intimidating and less dominating, you know, then do that, build that into your exam. But this slide is just intended to denote and pay respect to the idea of dividing things up into major categories: forelimb, hind limb, major regions, elbow, forearm, carpus, and with each of these come their own list of differential diagnoses. What I'm going to do is I'm going to the bulk of the orthopedic exam itself, I'm going to kind of pass the buck to Dr. Ian Holsworth, whose YouTube video, you guys could find this video yourselves on YouTube after the post facto if you wish. But basically, I wanted to take advantage of somebody that already created a really high quality video of the orthopedic exam. And to boot, he's more handsome than I am and has a pretty cool accent too. But major notes I just want you to keep in mind as you're watching this is, you know, most joints, as far as what are the things to keep in mind with joints. Most joints, you're going to want to feel for the collateral instability with that particular joint locked in extension. You know, particularly that's true for the hock, that's true for the carpus, it's kind of true for the stifle. Yeah, the elbow, yes, it's true, but for the elbow, you can check collateral instabilities also with pronation and supination. He'll go over that as well. But just in your brain, think, if I'm trying to check for collateral stability in a joint, I should lock that joint in extension and then just check for the collateral stability. Because for the tarsus in particular, especially even if I confound that and I say a tarsus of a cat, say cats in general just have loosey-goosey joints to begin with. So something that might actually be normal for a cat might throw you for a loop. But so if you try and check a cat's collateral stability of their tarsus, and you don't have that hock locked in extension, you really could be tricked into thinking that there's tarsal collateral instability or rotational instability, you know, when there really isn't. So for that one, pointer, lock the joint in extension, then test for collateral stability. Don't forget about hyperextension. You know, I mean, partial cruciates where you can't feel the, you know, the cranial drawer isn't obvious, or the cranial thrust isn't obvious. You can hyperextend that knee and stimulate that partial cruciate tear. And if you get a wince or a pain response on that side that's asymmetrical to the other side, that is useful information. The same is true for pain generated from the elbow. You can actually generate a wincing on an elbow, on an arthritic elbow that might be asymmetric to the other side. So don't forget about hyperextension of a joint. Also, don't forget about you know, as far as the joints, joint effusion, crepitus, periarticular fibrosis, make notes of all those things in your record, because that's useful if the case has to go on to referral. For the bones, feel for localized bone pain. Is there a swelling associated with, or is there pain associated with a certain swelling? Are the, you know, in the terms of joint, crepitus usually means arthritis, could mean other things, but arthritis is one of the things that it means for a joint. Crepitus for a bone kind of starts to point you in the direction of a fracture that you should be uncovering. So without further ado, let's go ahead and get this video started. With actually, one thing I will say, I don't want to forget to say also, I want to, as you watch this video, I guarantee you one of the things that's going to come to mind is, jokingly so, almost to a comical degree, nearly none of our patients are going to be greyhounds with absolutely perfect anatomy. I recognize that. And nearly none of our patients are just going to sort of sit there quietly and let you do all of these manipulations. I recognize that as well.
Placing my body up against the patient so they know where I'm at. I always commence my orthopedic examination by gentle but thorough palpation of the spine. I feel for thoracic or lumbar pain or spasm by palpating the paraspinous muscles, localizing the pelvis, feeling the lumbosacral junction, performing a tail jack if necessary, and all allows the patient to feel for you before you palpate the limbs. In the pelvic limbs, I commence with good support, and the first thing I will do is check the patient for proprioception. In this patient, proprioception is present and is normal. I tend to commence my pelvic limb exam by mobilizing the pelvic limb. Start to move the hip, start to move the knee, start to move the hock to get the patient used to the process. I tend to commence from the hip by flexing of the hip, extending the hip, and looking for signs of pain or loss of range of motion. When moving down more distally, it's good to support the limb, keep the body against yours, and when examining the foot, run the digits through a sequential check for range of motion, pain, and resistance. Palpating the phalangeal joints, the metatarsophalangeal joints for thickening, fibrosis, or abnormality is advisable. When moving down to the hock, it's a good idea to extend, flex, palpate for stability in both a extended and a flexed position. Placing the foot back to the ground is helpful to feel the Achilles mechanism and make sure there's no thickening or change. Palpating the long bones of the metatarsus, the distal tibia, and the femur is helpful to determine the presence of bone pain. The stifle is best examined by checking its range of motion, full flexion, full extension, the presence of an increased internal rotation, the presence of patellar instability or effusion in the joint. These all should be determined. Stability should be checked by both thrust test and by cranial draw. Both these exams can be done with the patient standing, or in some cases, it's wise to put the patient into recumbency to allow you to palpate those areas with a more relaxed patient. When moving forward on the patient, I will straddle most patients so that they can feel where my legs are, they feel where my body is, and I'm able to control their body position, particularly their desire to sit. When moving cranially, we will examine the cervical spine, its range of motion in all four directions, passing it back to my technician so that we can then palpate the cervical spine in terms of the vertebra, possible pain sources or pain locations. Palpation of the thoracic limb starts with extension of the shoulder, flexion of the shoulder, flexion and extension of the elbow, before I move distally to look at the foot. Palpation of the foot should include, as in the hind limb, all the digits so that the manus is thoroughly palpated for joint pain, joint abnormality, or long bone issue. The carpus should be flexed and extended, the elbow flexed in a neutral position, extended, and in particular, pronated flexion should be performed to stress the medial aspect of the shoulder. A thorough orthopedic examination is invaluable in determining where the focus of pain may be in a patient and allowing you to proceed forward into diagnostic imaging.
Thank you, Dr. Holdsworth from Ventura, California. Now, I want to fully respect the fact that, yes, I mean, everything that he said, it does represent a pretty thorough exam. I also want to be respectful that, you could hone your exam, it can be dumbed down in some degree as long as you're trying to rule out the most common things. Now, every detail of the exam that he pointed out would pick up, I mean, this is sort of the orthopedic exam of the orthopedist even, you know what I mean? But I'm saying that it's certainly to flesh out your differential list or to flesh out your orthopedic exam. I mean, even just doing the basic palpations for the most common differential diagnoses can certainly get your, can certainly help to hone your exam and make for a better client and patient experience overall moving forward. I said this already, basically just, I just basically changed this to the recumbent exam, but like I said, with recumbent versus standing exam, it might just be a matter of the confluence of the dog's comfort or the patient's comfort, the cat's comfort, and your comfort in terms of the least stressful way to get the palpations in. But again, in thinking in terms of differential diagnoses, the differential diagnoses might influence the different palpations that you're doing. In terms of the most common things, let's go ahead and talk about it. I mean, cranial drawer, of course, is the most common thing. It's cranial drawer for the most common diagnosis of ruptured cruciate ligament for a hind limb. As an example, let me just go ahead and go over these landmarks. This video loops for the cranial drawer as well as the cranial tibia thrust. But in terms of the cranial drawer, let me point out that your thumb here is on the dog's lateral fibula. It's not just on it, it's actually wrapped around behind it. Your forefinger here is on the patella. And again, it's not just on the patella, it's wrapped around it. The whole point of these landmarks, you have to remember these landmarks are useful to tell you where to put your hands and your fingers. But what I really want you to concentrate on is you're actually wrapping your entire hand around this. The point of these 4 reference points is that they're the bony prominences that give you the most leverage to hold that entire bone. So this hand is trying to stabilize the entire femur but concentrated at the stifle joint. And this hand is trying to stabilize the entire tibia, but concentrated at the proximal tibia. So in other words, those points would be the lateral fibula, wrap your thumb behind it, wrap your finger over the patella, and then wrap your whole hand around the leg to try and grasp that bone for good leverage. Same thing is true. Put your thumb behind the fibular head, and then wrap your finger around the tibia tuberosity and grab that whole tibia with your leg. And then what you have is you have this area isolated with your 2 hands, and then you can palpate for cranial jaw. For cranial tibial thrust, let me see if I gotta go back. For cranial tibial thrust, see if I can't pause this. Oh, let me go back again. Sorry. See if I can't pause this for cranial tibial thrust. Let's see. Can I? Let me just let it loop. Okay, they won't let it loop. Okay, so for craniotibial thrust, this hand here will be trying to hold the femur still while this hand flexes the hock. The reason why I say it needs to be holding it still is because when you flex that hock, the whole mechanism is automatically going to want to make that stifle flex. So what you need to concentrate on is actually holding that femur still while you're flexing the hock. And if you can see this tibial tuberosity popping forward relative to a reasonably still femur, then that's cranial tibial thrust. Now moving on, I just found this cool video that I can't explain exactly how they did this with fluoroscopy. I mean, how can you not see that person, the bones of that person's hands? I have no understanding. But that being said, this is basically what you're trying to reproduce. If you had X-ray vision, then the dog with the torn cruciate ligament, you can see the tibia popping forward relative to the femur. Izzy finds that video kind of gross, which is kind of funny to me. But here's the stable knee. You can see that they actually move their hands a little bit more proximal to get better leverage. And then the torn cruciate knee. You can see the tibia popping forward relative to the femur. I thought that was a pretty cool video myself. So, hind limb, tarsus, hock, hip joint. So as I was saying before, it's useful to get the most common palpations under your belt here. So for a hip, for example, like one of the things that you can discover pretty quickly is do they have a non-weight bearing lameness because the hip is luxated? Well, you can palpate for that. There's bony prominences, i.e. in most dogs. I get that. There's some English bulldogs where you have a hard time finding these prominences, but this dog, for example, has at least an inch of fat anyway. But so you should be able to feel the ilial wing, the ischiatic tuberosity, and the greater trochanter. Those 3 points, this, and this. So this is the ilial wing, this is the greater trochanter, and that's the ischiatic tuberosity. Those 3 things should form a triangle in the normal dog. And in the dog with the craniodorsal hip luxation, this trochanter lines up with the other 2 points. And obviously in the case of the caudo-ventral luxation, it also fails to form a triangle. It also forms a straight line of sorts. So that's another useful tidbit. Here's a video showing the concept of the ortolani, so that you can sort of get that.
To perform an ortolani test, the pelvis and the femur are held in 90 degrees angulation. Then the femur is adducted while the thumb of the other hand is positioned over the trochanter. Under pressure, the femur is then pushed dorsally and the femur head subluxated when the hip is dysplastic. While holding the pressure, the femur is abducted until the femur head flips back into the acetabulum, which is felt with a click or with the thumb on the trochanter. The same procedure is shown again on a different angulation, adduction and repositioning of the femur head, and positive Ortolani sign. Here we have a dog under sedation where the Ortolani test is performed. You can see that the trochanter flips back into the acetabulum. Much nicer is the situation when you have the hair clipped. In another dog, you see now that the trochanter and the femur head are flipping out and into the acetabulum quite easily. The dog is severely dysplastic.
I recognize them leveraging YouTube videos a lot here, but it's just one of those things where, it's hard to do this sort of thing over Zoom. But so I wanted to take the opportunity to just offer it out there for clinics out there that want me to come to your clinic and do this in person. If you find that more digestible, you can certainly contact Izzy and we can arrange for that kind of continuing education. Usually Thursdays are the best days for me, just in general. So that being said, let's just jump into a case study. Here's an example. You get a 2-year-old dog, 60-pound male neutered border collie with an acute onset right hindland lameness that yelped while he was playing fetch. And the dog presents with a non-weight bearing right hindland lameness. On your exam, you feel stifle effusion. The dog is really reactive to stifle palpation. There's no obvious cranial drawer or instability noted, and the remaining of the orthopedic exam is within limits. So on our list of differential diagnoses, partial craniocruciate ligament tear, certainly. The one caveat I'll say there is that cruciate ligament tears, the nice thing about that diagnosis is that the severity of the limp tends to almost correlate conceptually one-on-one with how severe the tear actually is. In other words, in general, the dogs with the more complete tears have the more severe lamenesses, and the dogs with the partial tears have more intermittent lamenesses. So certainly a partial tear could present non-weight bearing, but in terms of the time frame, the partial tears intermittently are non-weight bearing when they've just actively and recently aggravated the partial tear, like when they first get up from a lying position after they've been laying down for a long time, or if they just slipped in the mud 2 hours ago, they still might be non-weight bearing on a partial tear. But as a general rule of thumb, the partial tears are not going to be non-weight bearing. So one of the things that one of the good tidbits or tips to keep in mind is if a clinical symptom is not really fitting your differential diagnosis, you have to think of other differential diagnoses. So the partial tear should have an intermittent and mild lameness. So when you don't feel any cranial drawer in a dog that's completely non-weight bearing, unless you're catching the dog like 5 minutes after they aggravated the partial tear, you have to start thinking about other differential diagnoses. Stifle sprain injury, similar idea. I mean, like let's say they sprained their collateral ligament, but it's not completely torn. They might be sore on it intermittently, but unless you're catching them within minutes or within an hour of an aggravation, it should be mostly a weight-bearing lameness as opposed to a non-weight bearing. Meniscal injury, general rule of thumb, meniscal injuries are very rare to occur in dogs or cats isolated like the human entity. It is reported, it is possible. It's just that the percentages of isolated meniscal injury in the absence of a near complete cranial cruciate ligament rupture is really rare. So in other words, think of it in general that meniscal tears nearly always are preceded by moderate or near complete cranial cruciate ligament ruptures. Fractures on this list, soft tissue injury could be on this list, that sort of thing. So this is a reasonable differential diagnosis. So then we have choices, you know what I mean? It's like, we certainly, there's always, this is a good try and true is say, hey, if the limp is mild and it just happened and maybe it's even improving, maybe we could try just NSAIDs and rest for a couple of weeks. And we could always get them back for x-rays if things aren't improving. Or we could just, you get an owner that wants to know right now and you get radiographs of the stiple right away. Or you say, hey, I don't really have that much experience in orthopedics, or I'm not that comfortable with them. I'm just going to send this lameness to a surgeon. Or hey, I like doing joint taps. Maybe I'll tap this dog's joint. So there's all these choices that you could do. Let's say, for argument's sake, that we chose the no radiograph route and going to submit it to us. Let's go ahead and just send this case to a surgeon. Let's say it was during COVID when all of us were backed out anywhere from 5 weeks to 5 months. And, a cruciate injury, we're probably going to prioritize on our appointment list for when we have our first non-urgent opening. And during COVID, that was certainly could have been a 5-week wait for them to get into our schedule. So then the dog waited 5 weeks to get into our schedule for a presumptive cruciate tear. The lameness had improved in some capacity, which partial cruciate ligament tear certainly can do that, especially with the help of carprofen. On our exam, we feel that there's severe stifle effusion, periarticular thickening. Okay, that fits. Decreased range of motion, crepitus, maybe. No obvious instability, so it's a partial tear still, maybe. Collateral ligaments are stable, but the dog is really reactive to palpation of the distal femoral condylar region. Okay, that's a little weird for a partial cruciate ligament tear. So maybe we missed a fracture. Maybe there's cancer growing in the dog. We don't know. Maybe there's an infected joint, and if left unchecked, it's worsening. Or maybe we're still dealing with that partial cruciate ligament tear, and it's just being stubborn. So we go ahead and take X-rays and discover a fractured femoral condyle. And so then we have to sort of, okay, what do we do with this? What are our treatment options here? It's kind of 5 weeks post-injury at this point. So usually fractures that have been around for 5 weeks aren't really all that, reducing them and fixing them at that stage isn't really that great an option anymore, because the blood supply's gone to trash, and sometimes there's already bony changes occurring in the joint now, or with the bone that make it impossible to fix. So surgical repair often is off the table here. Could we maybe get the fragment out of there and help them walk on the leg? Well, arthritis might delay that. I mean, I wouldn't necessarily jump at amputation unless the dog is exquisitely painful. But that being said, all of these could be viable options depending on the state of the dog at that. But you obviously picked up on this. This is sort of my plug to try and, convince you guys to take X-rays before you refer. You don't necessarily have to tap joints, but I know that some of you have that expertise. And by all means, if you think it's necessary, then I'm not going to tell you not to do it. But X-rays is something that nearly every clinic has. I recognize the philosophies of trying to save the owner money. I recognize the fact that, maybe not all of your staff is set up to take good quality X-rays, and you're anxious about that. On that front, I also want to throw out there a plug to say, hey, our staff is also, if you set it up through ISI, we could come out there and show your staff how to take well-positioned X-rays if you want to set that up as an in-person continuing ed or laboratory for your clinic. Just contact ISI and we can certainly get that set up for you guys. Yeah, it is true that surgeons often want their own images, but there's the difference between diagnostic images to try and figure out, well, what's going on, versus preoperative planning X-rays that we might take with certain specific positioning. I think there's a value that you can present to the clients for both, especially in the case of the weird presentation. I'm going to concede and respect the fact that if you are very confident that the dog has blatant, like their cranial draw and their cranial tibial thrust is just slapping you in the face, it's so obvious. Yes, I don't think you need x-rays for that. You could probably just expedite that referral and we'll take it from there. But on the other hand, there are just weird cases like this where it's like there was a non-weight bearing lameness, but you didn't feel drawer. You know, you're scratching your chin. There's something not right about this. Maybe we should, maybe we should take x-rays. This is a pretty exhaustive differential list, but these are the things that you could uncover with just basic lateral AP x-rays. So just wanted to, sort of dumb it down a little bit. Yes, this looks exhaustive. Yes, this looks intimidating, but it can be simplified with a set of x-rays. And then when your client calls us for the referral, they already have a diagnosis in hand, and that makes the consultation appointment that much more efficient. Of course, there's more obvious, detriments to not taking the x-rays ahead of time. They might be thinking that they're coming to see us for a partial cruciate ligament tear, and we discover an osteosarcoma. So if you want us to give you some words for value for the client, maybe instead of saying the surgeon will want their own images, maybe we should save you money, or surgeons always repeat their own x-rays. I'd rather have you say to us, it's probably a cruciate, but we better rule out more time-sensitive or ominous things first, so the surgical clinic will know how to prioritize your appointment. Because if it's just a cruciate, we're probably just going to find the earliest opening for non-urgent cases. But if it's a fracture, we're going to try and find a place to squeeze them in, so to speak. Obviously, the cruciate is, like I said, is the quintessential example that I'm using. It's not the only orthopedic problem out there, but you can sort of extrapolate this concept to the elbow, to the forelimb, to the hips. It's sort of my plug to try and get those of you out there that are a little bit anxious or nervous about starting with x-rays, or like I said at the beginning of the talk, if maybe your schedule is not really structured for you to easily take x-rays, maybe you don't have enough staffing. I get it. There's a lot of factors that govern whether you're able to take those x-rays or not. But as opposed to these philosophies, I want to give you the words that you might find useful to your client to point out the value of your x-rays before the referral process. So in summary, I'm happy to go over orthopedic exam in person if you like. Just call us and get that set up. Or if you want our staff to show you how to take x-rays, then we certainly can set that up as well. But I'm really I'm grateful for all of you that attended, because it means that you're trying to flesh out that orthopedic exam, and I do overall think that does lead to a more efficient and better client pet experience moving forward. Also plug to say, hey, if you're not exactly sure what you're looking at your x-rays, or if the radiology report comes back and says consultation with an orthopedist is recommended, certainly you can just have the owners call us and set up an appointment. But some of these cases are non-surgical, and you might pick up on that fact. It's like, well, the radiologist says to consult with an orthopedist, but is this really going to need for a surgeon to cut them open? Feel free to, I think calling us or emailing us does qualify in abiding by the radiologist's recommendation in consulting with an orthopedist. We can come to the phone, we can look at your x-rays over email, we can answer your questions, and we can help direct where the right place is for them to go. That being said, I'll turn it back to Izzy for me to try and figure out how we handle the Q&A. Do I just click on the Q&A? Mm-hmm. All right, so then I'm going to click on the Q&A. And any thoughts on Librela in patients that have both ortho and neuro issues? Oh, yeah, that's a great question. I have the same question, so if it's helpful. There's so many things. I mean, Librela has been this amazing addition to our tool belt that it's changed the industry. And I think it's going to continue to change the industry. What we need to recognize is that there are the things that we know about Librela, which is basically all of the data points that they have that allowed for the FDA approval of its use. But that being said, there's a whole lot about Librela that we have no clue about, just because it's only been out for so long. For example, what are the long-term, potential risks or benefits of Librela? You know what I mean? What happens 7 years into Librela? I'm not sure any of us know the answer to that. So in terms of like having both ortho and neuro issues, as far as I'm concerned, when you're trying to make a dog's life better, use everything you possibly can to make the dog's life better. But be honest with the clients in terms of the things that we know and the things that we don't yet know about the product. I guess in terms of, I don't know if I'm answering that question, so you certainly can sort of revise that question or ask in a different way if I didn't answer that question appropriately. But I couldn't see well earlier. Is the pronation of the elbow examination flexing the elbow towards midline while the carpus angles away? This is testing for medial coordination. So pronation, if I were to describe it to you using my own hand. So this is the elbow. Pronation is rotating the wrist in this direction. And no, that's supination. This is supination. Opening up your hand this way is supination, and pronation is doing it in this direction. So yeah, what you can do in terms of medial coronoid, I mean, in the elbow, that's often described to help you, like dogs that that pronate more than their normal side might actually have lateral collateral instability, and dogs that supinate more than their contralateral side might have medial collateral instability. You can also use the pronation or supination to try and kind of make the palpation for the medial coronoid disease, more pronounced. But as far as medial coronoid disease, it's sort of like you kind of have to get an anatomy textbook out or a model out and look and see where the coronoid is and press your thumb on it. I mean, it's one of those things that I might need to show you in person, but you can sort of press your thumb in the area of the medial coronoid, basically just, a couple of centimeters off of the medial humeral epicondyle. You can sort of find the spots to squeeze to stimulate the medial coronoid. Pronation and supination are intended for different things. By the way, Librela will tank, ruin, in early myasthenia gravis patients. So that might be where the question was earlier coming from. That's good for me to know, because I didn't actually know that. So thank you for that. There are great answers on VinForm about Librela with neuro patients. So yes, thank you for that input. That is useful, and I am all the better for knowing that. You answered the Librela question perfectly. Okay, well, there's that too. So let's see. I forgot to do a screenshot. Any chance you can share the slides afterwards? I think Izzy can answer that question for you. And when a patient has a scheduled TPLO in a couple of months, what do you recommend for treatment options while the patients wait? Strict rest, pain, medications, until their surgery. Yeah, I mean, it's different for every patient and for every pet. But as a general rule of thumb, just broad sweeping generalization, when they ruptured their cruciate ligament, I'm going to throw it out there, and I might say some controversial things here, but like when they ruptured their cranial cruciate ligament, the only thing left they have to ruin in their knee is their medial meniscus. So yeah, I mean, I think you could rest them to, you could use the philosophy that you rest the dog in order to prevent the medial meniscus from tearing, because you'd love to preserve the medial meniscus if you can. Because the dog might end up having a better outcome if they have an intact meniscus. So sure, that's one possibility. But going the idea that most, partial to near complete tears of the cruciate, at least 50 to 60% of them already have a torn meniscus by the time they present to you. Then if they already have a torn meniscus and they already have a completely torn cruciate ligament, the only thing that they're really worsening with activity is just that sort of that low-grade progression of arthritic disease that's in the joint, so that inflammation that's in the joint. Now, from a patient experience perspective, I recognize that a sore joint is sore. You know what I mean? So in terms of activity restriction, this is what I often say to my clients when they ask me, is that if my daughter comes to me and she's poking her pinky in her eyeball and she says, "This hurts, Dad," I'll take my hand and I'll take her pinky away from her eyeball and I'll say, "Okay, well, why don't you not do that?" You know? And so that's my way of saying, well, yes, more activity they might pay the piper that night if you play ultimate frisbee with them, despite the fact that they've got a torn cruciate ligament. So to be kind to the patient, maybe not let them run the Iditarod on a torn cruciate ligament, because they're just going to be really miserable that evening. But from the perspective of, I'm going to try and rest the dog so that maybe they have a chance to heal something. I think what we should all recognize, so I'm glad you asked this question. I think what we should all recognize is that Mother Nature, to my understanding, does not actually have a capacity to regenerate torn cruciate ligament with rest or anti-inflammatory drugs. So let's keep in mind what our goal is here. Our goal, when you're trying to, take a partial tear and tell the owners to rest the dog and give them anti-inflammatories for 2 weeks and see if the lameness goes away and never comes back. Oh, and if the lameness comes back, come back and let's take x-rays. Let's get it straight. What we're not trying to do is we're not trying to get a torn cruciate ligament to quote unquote heal, because there is no mechanism for the cruciate ligament to regenerate or heal. The lameness might resolve, but the lameness resolves because the inflammatory cycle has been calmed down by your anti-inflammatory drugs. But what's left behind, if the hundreds of cruciate ligament fibers and 10% of it ruptured, a little firecracker goes off in the joint and it's burning. That's why the dog is limping. And then two things will kill this fire down a little bit. One is time alone. Time alone, if you don't do anything, this fire will die down to a pilot light that's still present down in there, to just a slow little trickle, and the limp will go away, even if they never saw a veterinarian. But if they see the veterinarian and you douse it quickly with anti-inflammatory drugs and rest, boom, the lameness goes away. But they didn't regenerate that 10%, or 20%. They didn't regenerate the ligament. What they did is you quelled the flame and the limp went away, but they're still left with only this much of the ligament left. And so that's why I was saying the partial tears have basically an 85% chance of turning complete someday, because you have these episodes where maybe like 10% of the ligament went 6 months ago, 3 months ago, another 10% went, 3 weeks ago, another 10% went, and then 3 days ago, it's all gone, and now the dog's limping all the time. And so that's the storyline in basically 85% of cases. 15% might stay partial, and then they might form enough periarticular fibrosis to provide the dog a functional outcome without surgery. But let's be clear, that's what's happening. It's not healing the ligament with rest. So, what else do we have? Anything else? Okay, well, I really appreciate you guys attending. I hope that answered a lot of questions, and hopefully I didn't offend too many people this time around. But yes, I want to take down the barriers of intimidation, and you probably heard it in my voice. I kept inviting you guys to interact with us. Call us, email us with your questions, or call Izzy and request that we visit your clinic, for various CE venues or whatever the case may be. How long does it take to form medial buttress? I'm going to say on the scale of weeks to months. So if you already have periarticular fibrosis on the knee, and the clients are trying to kind of, if there's do some forensics as to when this occurred or how long has this been going on. If you can feel medial buttress, it's been going on for at least a few weeks. Beyond that time, it kind of depends. The more complete the rupture is, the faster you'll get these physiological compensations. Whereas the more incomplete the tear is, the more partial the tear is, the slower you get those compensatory mechanisms, which means that medial buttress could mean anything from, like, if it's really thick medial buttress, it could be a complete tear that's only been around for a few months, or it could be a really, really partial tear that's been around for a few years. And so you kind of have to think of it in those terms. Hopefully I answered that question. All right, cool. Well, we're at that stage where if that's all you came for, then you certainly can log off. If there is anybody, we'll wait a couple minutes. I guess if there's anybody, or you know what I'll do is I'll just go ahead and continue on. As I said at the end, that I did have a few graphics on the internal sort of referral process here. You know, the fact that I told you that we have sort of a surgical department where you're trying to, kind of shunt cases in for clients that have decided you've already made a diagnosis. It's definitely a surgical diagnosis, and the owners definitely want surgery. Clearly those go down the surgical pathway, but then like all the way to clients that have a chronic condition that there's no surgery out there that'll help chronic elbow dysplasia, except for total elbow replacement, for example, which we don't perform here. And so these chronic elbow cases, do they see the surgeon, or do they see our orthopedic medicine department, or do they see our rehabilitation department? So I've got a few, for those that want to stick around, I've got a few slides just to kind of go over that a little bit. So basically, as I said, you've got, two arms of our clinic that are very obvious: the surgical arm for the obvious surgery cases, the rehab arm of sound for the obvious chronic cases that just want kind of chronic pain management advice. And then there's this kind of weird place in the middle where you've got this like, well, is it acute? Is it subacute? Or, I mean, within this category, it's like, well, I don't know. Do they need to, sometimes it's cases where you don't even have a diagnosis yet. Sometimes it's cases where it's like you did all the x-rays you could and you don't have an answer. And I'm not sure, maybe it's a soft tissue thing. I guess that's another thing is I should have mentioned it during the CE, during the talk, but I'll mention it now, is that most things that actually require, it's a broad sweeping generalization, but most things that actually require surgical intervention, most things that actually require us to take a knife to skin, usually show up on a set of x-rays. That's kind of one of the messages I was trying to get across during the talk, which means that, well, what if you take x-rays and the dog clearly is not neurologic, and you take x-rays and there's something that's causing this dog's limp, but it's not showing up on x-rays, then it's likely soft tissue in nature. Like it's likely muscular, it's likely tendinous, i.e. we're not likely going to take a knife to skin in those cases. And so where do you send that? You know what I mean? A dog that clearly has a limp, but all the x-rays are normal. Well, we've got an infrastructure here to set you up for that. That's our orthopedic medicine department. Also in that category, I would say that you've got, let's say you've got a client that actually does have a surgical disease diagnosed, but you have an owner that's not so convinced that they really want surgery or not, but they kind of want to hear all the options. Oh, well, I want to hear the option is what's the surgery option? What's the non-surgery option? And so, as I said, that's kind of like a fence sitter, right? That's somebody that's smack dab in the middle. It's like, do you send them to the surgery side? Do you send them to the rehab side? They don't know. They want to talk to a specialist. They want to talk to somebody. You should be comfortable that you can send that to orthopedic medicine. And orthopedic medicine, it's my broad sweeping generalization of saying, well, that's, surgeons and our rehab docs are all considered orthopedic medicine. It's just that more often than not, the clients that are kind of leaning in the non-surgical direction, we kind of tease them towards the sound department and the doctors on the non-surgical side. So in general, that tends to be things like acute lamenesses, broad sweeping generalization. They tend to be surgical, the more subacute to chronic cases. Again, broad sweeping generalizations, they tend to be more, kind of soft tissue oriented or need like more chronic, long-term advice, chronic advice, and that's our sound department. And then these acute somewhere in between, or a client that hasn't made up their mind up yet as to whether they want surgery or not surgery. Keep in mind, our rehab docs, you know, they're pretty smart. I have high respect for them. They actually can have the surgical discussion with them as well. It's just they're doing it from the perspective of the rehabilitation doctor. But they do have that ability to help an owner tease out whether they're interested in surgery or not. And so you can always send it to orthopedic medicine if the owners aren't sure, you know, or they're dubious, you know, if they're really, you know, like, well, I'll talk to the surgeon if you really want me to, but I don't really want surgery. Okay, don't send that to the surgery department, send that to orthopedic medicine. Does that make sense? Orthopedic medicine, I mean, as I said, and previously, email us, call us if you have any concerns about where this should go. We're here. You can email me, you can call me, us, not just me. You know, there's 5 of us here. So somebody should be available to take your phone call. And if they're not, we should be able to get back to you in a pretty timely fashion. So this slide, I recognize when I put this slide in that this sort of dates me as well. There's a bunch of the audience that won't even know what this reference is. As far as, see, Izzy doesn't know that this is one from When Harry Met Sally. But anyway, I'll skip that. And sometimes this is more contemporary, I guess, right? Sometimes we just don't know Jack Diddley and we want to talk to somebody. So, you know, orthopedic medicine, you know, they do have additional diagnostics. Let's say your x-ray machine wasn't working, or let's say, let's say you don't have x-ray, whatever the case may be. We certainly can continue the process here through the orthopedic medicine department. So the idea here is if the case hasn't been officially diagnosed yet, but you're sending it to us for a further workup to get a diagnosis, send it to the orthopedic medicine. Not surgery. Surgery, we're trying to make it simple. We're trying to simplify the surgery, see the surgeon if the owners want surgery for a surgical disease. If the owners don't want surgery, it's sort of leaning away from the surgeon, then we've got an orthopedic medicine department. Or if we don't know if there's a surgical disease or not yet, orthopedic medicine department, and then they can continue the workup. The orthopedic medicine department can do things that require sedation or anesthesia, PRP injection, stem cell injection, shockwave. They can fit the dog for orthotics or prosthetics, assistive devices. As I said, yes, things that require sedation or anesthesia, like shockwave. You guys may have heard about shockwave or seen it in our records or whatever, but you might not know what it is. But just to give you an idea, it's therapeutic ultrasound, basically concentrated into what feel like physical pulses. It's ultrasound, not electricity. Of course, you need electricity to generate those pulses, but these are ultrasound pulses. And the way my brain thinks about it is like, I wrap my brain around it by thinking about it as like a really deep tissue, like hardcore Swedish deep tissue massage, because basically you're using ultrasound sound waves to generate this. Now, this is hope this is okay, Leslie Ide, that I'm using your image here. So a good plug for Leslie Ide at Total Canine. She's a great doctor in terms of sports medicine. So, but this, just to give you an idea, this isn't actually showing. I was hoping that this video would show with the sound. But the sound is usually pretty obnoxiously loud, but I guess it's not showing. It must have. You know what? There might be an actual equalizer or something like that in the Zoom that automatically cuts out loud, obnoxious sounds, because that thing is loud, it's obnoxious, and the dog needs to be asleep because it's really painful as well. So unfortunately, that didn't produce very well. But anyway, that was the point of that video. So sound, when it's obviously more like chronic, like you've got a dog with elbow dysplasia where the x-rays already show that the arthritis is horrific, but you needed to send it to somebody. Well, like I said, we don't perform total elbow replacements here. They do those in Sun Valley with Dr. Randy Aker, but we don't do total elbow replacements here. So that dog actually in the Pacific Northwest does not have a surgical option for management. So, it's mostly arthritis management. mobility and pain management for chronic disease, those certainly can be sent to our sound department for rehabilitation in consultation with the sound doctors. They've got modalities, all the things that you can think of and that you've heard of, like the laser, the underwater tread therapeutic exercise, the acupuncture, all that sort of stuff. Librella's in there, but of course you guys have Librela in your own stocks, but Synovitin's in there too, which I'm positive you guys don't have that in your stock. So me personally, I don't know how the rehab docs look at it, but I like looking at a lot of these modalities for long-term arthritis management is like throwing spaghetti or spitball against the wall and seeing what sticks. And your goal is to take as many of these spaghetti strands or spitballs as you can and cover that wall as much as you can. Whatever sticks, you use the rest of their life. Whatever doesn't stick, you just disregard. Well, let's say it dries up and then falls off. Well, then you moisten it again and you throw it up against the wall again. So, but yeah, that's basically the summary of the referral process here. So I'm hoping that helps to clear up any confusions that it might have generated if your clients are calling us and we're trying to figure out where to put them in terms of how much of the diagnosis has been, how much of the diagnostics have been done, how many of the diagnostics still need to happen, how interested are the clients in surgery, or is this a case that doesn't require surgery? Does that I can see that generated a Q&A, so let me take a look at that. What are my thoughts on the Assisi loop? What I'm going to say, I think it's probably, that's not my area of expertise I'm going to have to throw out there. What I would say is that's certainly an area of expertise for all of our rehab docs here. For what it's worth, I'll tell you, we have a bunch of Assisi loops here, so if that means anything to you, they use them all the time. We have them on our post-operative patients all the time. But in terms of the literature that's out there, the efficacy, this is why I refer to some of these measures as spitballs that you throw against the wall, because a lot of it right now in this day and age is all left to empirical data and empirical experience. If you find something works at your practice, you continue it. You know what I mean? And oftentimes when clients ask me about various modes and modalities of non-surgical management of arthritis, I often gear them back towards your clinic individually, not because I'm just trying to skirt the answer to the issue, but I'm usually telling the owners that most veterinary clinics conglomerately have come up with protocols that they have found work in the grand majority of their geriatric arthritic patients, meaning like there has been already a tested concoction of things that you guys have come up with that over several doctors in your practice and over several thousand patients, you say, hey, I find that this works tremendously. And whatever that concoction is, I'm all for it. I'm supportive because you guys have vetted it and you guys have used empirical data to create that. And so there's so many products out there in terms of the joint supplements and whatnot. And there's so many competitors out there that I think, needless to say, no singular one has won the battle for every single patient. So a lot of these products do end up being trial and error, and different patients, metabolisms of different oral medications, for example, might be different for other pets. The Assisi loop might work wonders for one patient, but absolutely doesn't touch another patient at all. So that's my long-winded way of averting the answer to that question. What else do we got? Any other questions? Any comments? Any insults or anything like that? All right, well, I'll take that opportunity to thank you all for attending. And again, offer you, throw that invite out there again to interact with us all you want. We're here for you. We're here for you via phone, via email, via CE Talk, or via visit to your clinic. You guys have a great rest of your day. You know where to find us if you need us. I do say to a lot of the clientele and the patients, well, we don't really wish that upon anybody. Hopefully you don't need us. I say to a lot of clients, I say, hey, I hope we never see you again. But you guys, I'm not gonna say that to you. I'd love to meet you guys as often as possible. I want to get to know you guys by your first names if at all possible. So feel free. Thank you very much. We off? Yeah. You will.